Good afternoon, everyone. Okay, my name is Tasaniya Rattanarithai Nopparat Jamjamrat. Now today I'm working with Sirilat Health Science Education Excellence Center, and today our center have very pleasure to be give an opportunity from Dr. Professor Peter Hathaway from Faculty of ICT Mahidol University to be our guest speakers today. Today he will gonna deliver the topic about intelligent virtual environments for medical training. Actually, Dr. Hathaway have a lot more experience in mathematics and also in computer science. And nowadays, he is also be a director in Mahidol Bremen committee as well. And this director, he will mention a bit more after this. Okay, please give me a chance to deliver the introduction about him for a while. Okay, Professor Peter Hathaway have experience not just only in computer but also in mathematics, and also he has a chance to be a vice president for academic affairs from AIT before. Nowadays, he is a director of Mahidol Bremen Medical Informatics Research Unit since 2018. Okay, I think today all of us will gonna have a good opportunity to have a chance to give to listen about his experience. How can he develop this research unit, and how's about the collaboration, and also how can we use the technology and medicine mix it together? Okay, Professor Hathaway, now the floor is yours.
Okay, thank you. Hello, everyone. So thank you for that very kind introduction, and it's a great pleasure for me to be invited to speak in this series on pearls in medical education. It's a bit of a daunting title for a series. I'm not sure I can give you pearls today, but I'm going to be talking about enabling technologies, so maybe I can give you a little bit of the oyster that makes the pearls. Let's see. So I'm going to start out by, as was mentioned, I'm the director of the Mahidol Bremen Medical Informatics Research Unit here at Mahidol University, and so I thought I would start out with a little bit of an overview of what this research unit is about, because the research I'm going to talk about comes out of this center. So let's see if this works. Very nice. Okay. So the Mahidol Bremen Medical Informatics Research Unit, or MIRU, is a university-level interdisciplinary research center that supports collaborative research between the University of Bremen in Germany and Mahidol University. And so we have quite a few visitors coming from the University of Bremen on a continuing basis, and also quite a lot of students and instructors going there. I think we have now sent a total of 110 students to the University of Bremen since we started this not so many years ago. So we're looking at addressing pressing problems in medicine and public health by coming up with innovative applications of information and communication technology. The research unit functions as a network. So we have quite a large network of partners. So first of all, within Mahidol University, quite a few faculties that are members of the center. Sirilat, Faculty of Medicine here, Sirilat Hospital, of course, is one. Ramatibodi is one. TropMed, Vet Science because they do a lot of disease modeling, and that's one of the areas that we focus on, and dentistry as well. At the University of Bremen, we have several faculties involved. Because of the breadth of the collaboration, Mahidol University and the University of Bremen entered into a university-level strategic partnership a few years ago. So this is not just at the faculty level, but at the university level, and there is a board that oversees this partnership and comes up with activities each year. So it's coordinated basically at the vice president level, the vice presidents for international relations of the two universities. As I said, we function very much as a network, so we have partners in France, in some other universities in Germany. Increasingly, we have partners in Africa because we do a lot of work on tropical diseases, and of course there's a big need in Africa. And then we work also with agencies like the Ministry of Public Health here in Thailand, and even with private industry. Biogens is a company that does mosquito monitoring systems we work with. And really, I would say all of the projects we do bring together international teams. So I can't think of a single project we're doing that doesn't involve people from at least two countries, often more. You know, it's these days you can configure research. You don't have to think it's yourself and you're going to find one person to work with, but you build up a group that's comfortable with each other and it's accustomed to working together. And when you have a new interesting project come in or some new interesting ideas, then you can basically configure the team that way. And I find that as to be a very efficient way to do research. Also a lot of fun. It's nice to work with people from different backgrounds. So within the research unit, we do work basically in two primary areas. One is addressing vector-borne disease and tropical medicine, but primarily vector-borne disease. And the other one is intelligent environments for medical training. So I'm going to emphasize in the talk today the second topic, but I thought I would just touch on the first to give you an idea of the scope of what we do. So within the first topic, we look at using advanced information technology to strengthen and link all of the processes involved in dealing with vector-borne disease. So things like surveillance, prediction and risk modeling, clinical decision support, and case investigation and disease control. So in the area of surveillance, we focus on mosquito vectors. So this is using image-based techniques like Google Street View to detect mosquito breeding sites. We've done this in Thailand. We're now doing this in Brazil. We were asked to help out in Rio. Prediction and risk modeling. Here we're building predictive systems. So we have a new project, for example, through Rockefeller Foundation, where we're looking at what will be the effect of climate change on disease transmission in Thailand. That's just one example. Clinical decision support. I'll show you a slide in a second on that. That's a project we're doing with Ajahn Panisidi here at Sirirat Hospital. And then disease control. This is, we've been building a system for the Ministry of Public Health to help with, it's basically case investigation, but also fogging, so intervention. So I'll mention this one. I'm not going to go into the other projects, but since we're collaborating with Sirirat on this one, I thought I would mention this. So Ajahn Panisidi and her colleagues had this wonderful data set of 18 years of clinical data on pediatric patients in two hospitals in Thailand, Khon Kaen and Songkhla. So they wanted to build a system to predict whether a patient would develop hemorrhagic fever using this data set. And we had already done work to do dengue diagnosis. So when a patient comes into a fever clinic to determine do they have dengue or some other febrile illness. So that work we had done, and they knew of that. And in fact, that system on the diagnosis is now being piloted in the Hospital for Tropical Diseases. So we've gone as far as now actually producing the application, and it's being used on a trial basis. The second system is now, if you have somebody with suspected dengue, will they develop hemorrhagic fever and when? So we're also predicting when day zero will occur. And we've been looking at issues like cross-site generalizability, which is that, because we have two sites, if you have data from one site and you build a model, will it work on another site? So this is a very important problem in machine learning these days. So I don't know how much you know about machine learning, but there's so much work that goes on where somebody gets a data set and they take a machine learning technique. It might be a traditional technique like decision trees or support vector machine or or random forest, or it might be a deep learning technique. And they build a model and then they say, okay, see, it performs very well. The question is, if you build it with one data set, will it work at other clinical sites? And unfortunately, often it will not. And this is a huge problem for machine learning because we can't be collecting data sites from every single hospital in the country, right? So we have to understand how can we build our systems so that they generalize to other locations, and what are the obstacles to achieving that. So that was one of the things we've been looking at with this system. And the other with the first system on diagnostic decision support, we've now been deploying it in the hospital. And again, this is an issue in machine learning. It's relatively easy to get a data set and apply some machine learning techniques and generate a model that performs quite well. Often diagnostic accuracy will be, or AUC will be, say, above 0.9, right? That's not, if your data is reasonably clean, it's not so hard to do that. Taking that and actually getting it to work in practice is actually a much bigger challenge. That's much, much harder, right? And there are all kinds of issues that need to be solved. And in fact, the performance on that data set, and that's usually what gets published initially, right, the papers, may not be replicable in the actual setting, because there are all kinds of things that can affect the accuracy of the system in terms of, mostly in terms of data entry, right? And so that's one reason we are now piloting this. And the second system that we're developing here with our colleagues in Siriraj, we will also be piloting. So we're now also developing the application for that. So also, again, to see how well does this work in actual clinical use. And what are the, how do we solve problems like getting it to integrate into the workflow, getting people happy with it, right? You have to have user acceptance. It has to actually have a positive impact, and that positive impact has to be perceived. So all of these kinds of issues. Right, so, so getting on with the main topic for today is intelligent virtual environments for surgical training, or maybe more generally medical training. And here what we want to do is explore the potential of the integration of VR environments with analytical techniques and intelligent tutoring systems. Okay, what we're looking at is that if you integrate these, you can provide things like formative feedback and tutorial dialogue with rich explanations for students, and new modalities for feedback that are not possible in the physical world. So rather than just using VR to replicate what's in the physical world, we'd like to explore how we can use it to provide something you can't get in the physical world. That's where it gets much more interesting and impactful. So I'm going to just go through a few examples of projects, and then I will go into more detail on one particular project that we've been carrying out over a very long period of time, and look at different kinds of studies we've done with that system. So the first system I'll talk about is a system for vascular access training. This basically focuses on needle insertion into the internal jugular, and what we, I'll just play the video. I hope this will work on here. Yes. And so you can see there is a student using the system, and the student is wearing a head-mounted display. So this is the system. It gives verbal instruction. So it's being run in instruction mode now. There are two modes, instruction and testing. And you can see that the student is holding this haptic device. And the haptic device gives touch feedback. So when you pierce the skin, you feel the elasticity. You hit a bone, you're going to feel that as well. And so you also feel the resistance as the needle is going through the skin and any tissue underneath. And you can see the system is giving instruction as to where should the needle be inserted, what should the angle be. And then what we're able to do once the student is finished is that, and I think you'll see this in a
ทำการแทง
second,
เข็มลงไปใต้ผิวหนังโดยลึกไม่เกิน3 เซนติ
right,
เมตรและ
talking about the
เพื่อ
depth
ไปขั้นตอนต่อ
now.
ไปทำการแทงเข็มลงไปใต้ผิวหนังโดยลึกไม่เกิน3 เซนติเมตร
And then we can just
เพื่อไปขั้นตอนต่อ
take
ไป
the skin away and show the student exactly where the needle
Right.
went.
So
Right? So this kind of instruction that it's a very simple way of providing feedback. Technically, it's easy to do if you have the model just to make the skin translucent, but it's a very nice way of providing feedback. So this is something that has been built now, and we're planning now the evaluation. We always do randomized controlled trials for the evaluations. The second system is something we finished fairly recently. So this is an immersive anatomy lab, and here we wanted to explore group problem solving. So in a VR environment, you're wearing a head-mounted display, you can't see other people, okay? But there are many situations where you want students to solve problems in groups. And so there, we thought it'd be interesting to explore the use of augmented reality, and we're using HoloLenses, so that the students can see each other, right? They can see, they get the body language, so the communication is much, much better. And so we built this system for teaching anatomy, and you see what the students are seeing here. So they have a human body. They can remove different anatomical parts and inspect them. They can also resize them. And the system also provides can also make copies. The system also has semantic tags, so it tells you the name of each anatomical part. Right, you see wearing the HoloLens there. So this is actually what they see. And the nice thing is that the interaction is also very natural. You can have very natural grasping. You can pick something up and hand it to the other person, and they can take it. So it really is nice for this group interaction. One project we just finished with the University of Oldenburg in Germany is that we use this for teleteaching. So we linked a group of students at Ramati Budi Hospital with a group of students at the University of Oldenburg in a virtual classroom together. But to have the students from there, of course, the students here could see each other, but they couldn't see the students there physically, obviously. So we had to render them as avatars, as like little robots. So it was this sort of unusual mixed modality where some of the participants were avatars and some were humans, and then they worked together that way. So we just finished this, and we're writing up a manuscript on it. Technically, it worked very well. Surprisingly, there were no problems with doing this over the internet, which is something we thought we might have problems with. In this demo, I just show the entire body. For that particular project, this was in orthopedics. We did the knee and the shoulder, and we had much more detailed models. Because the model you see here is too simplistic for teaching purposes. We were also able to take those models and produce pathologies, so different injuries of the shoulder and the knee, to teach the students about what happens if there's an ACL rupture, things like that. One technology we've been experimenting with recently is eye tracking. So eye tracking is interesting because you can get information about students' focus of attention. And besides focus of attention, also just how the eyes move can tell you something. This study we did, this was actually not VR, this is a cadaveric study where we used soft cadavers, and we had students and experts carry out diagnostic shoulder arthroscopy on the cadavers. And we looked at, could we, based on the eye tracking data, tell the difference between students and experts? And it turns out you can. So you can build a machine learning model that says, this is a student, this is an expert, based on this sort of rather low-level eye tracking data. Another thing we did that I found even more interesting than that is that we were able to detect when students became confused. So students oftentimes, as they were navigating, would become disoriented within the joint and became confused. And based on the eye tracking data, you can actually tell if the student has entered a period of confusion or not, which could be useful for an eventual automated teaching system. So this was our first work with eye tracking that was actually done with the University of Tübingen that has a very, very strong eye tracking group. And then the last system is a dental simulator, and this is what I'm going to be talking about for the rest of this talk. And so this is an immersive VR environment where you have the room, and then you also have a virtual patient. Let's see. With sound, and you have a fully drillable tooth. You can choose which tooth is drillable. You also have a dental mirror. And the idea here is to be as realistic as possible in terms of the graphics, but also the haptics, that the feeling is exactly the way it should be. So this is what I'm going to talk about for the rest of the talk, because this is the system where we've done the most different kinds of studies. But what I want to emphasize is what I'm talking about here are general technologies. So, you know, I'm demonstrating this in the field of dentistry and endodontics, but it doesn't mean that this cannot be applied in other areas, right? If you're doing work, really serious work in medical VR, you have to choose some medical domain and get very good at it, right? You have to do things as realistically as possible. So it's hard to do too many different medical domains. You choose one, but you can use that to test different kinds of ideas. And that's what you'll see, is that we're testing all kinds of different ideas for how can we generate feedback, how can we analyze procedure, how can we provide intelligent instruction, things like that. Okay, so let me get into the next set of slides. Okay, so so in this part of the talk, I'm going to focus on root canal treatment, okay, which is one of the more challenging procedures, and I'm going to talk about the one particular part of that, which is access opening. So root canal treatment, you know, you need to open access to the tooth. And then do some cleaning of the roots with these very thin files, and then cover up the opening again. That's called obturation. But what I'm going to focus on is the second step, this access opening of the tooth. Sort of surprisingly, that gives us plenty to work on. So this is the simulator we built. It's a VR-based simulator. We use, you see a student there using the system. We use two haptic devices. One controls the drill and one controls the mirror. Let's see if this, oops, go back. Okay. The student wears a head-mounted display, so the student gets a 3D stereoscopic view of the patient. And so we provide haptic feedback and the drill sound. And with the haptics, we have a 3D model of the tooth. Since a tooth is made up of various materials, so enamel, dentine, pulp, and the materials have different densities. So to get the haptics right, you have to model the tissue density. So when you're drilling through a dense type of material, you feel more resistance. Okay, and that's exactly what we do. This is, there you go. You see the student sitting there using the system, and you see the patient there on the left. So that's on the left what the student sees. So the one haptic device is controlling the handpiece, and the other one is controlling the mirror. Actually, the mirror we don't provide. You don't need haptic feedback for the mirror, really, but it just is a convenient device to control it. Okay. And so, so what are the interesting things to look at here? Well, probably the first important thing is, and I should say, this system was developed as a training system. Okay. So the first important question is, well, if students learn using the simulator, does that translate to the real world? Okay. So it's fully possible that somebody can get very good at using a simulator, but it doesn't help them in the real world at all, right? So I don't know, all kinds of computer games you can get very good at, it doesn't do anything for you in the physical world. So this is basically, I would say, the first key question one wants to answer. And so we did this with a trial with an experimental group and a control group. The experimental group was trained on the simulator. The control group was trained on what's called a phantom head, which you see on the right there. No, this is laser pointer doesn't work. That's okay. So there was a pre-test using extracted teeth to see how well do the students perform this procedure. And then 3 days of training with the simulator and with the phantom head. And then post-test, again, on extracted teeth, right? So because the pre-test and the post-test are on extracted teeth, now you can measure this transferability to the real world. So it turns out in both cases, and so what you see here is that the higher score is worse. So this is showing the basically number of errors or the error score. So higher is worse. So in both of them, they started out with error scores around 6, 6.5, and in both cases, the errors reduced significantly after the training. The other thing that we saw with this is that this difference, so the reduction in error, was not statistically significant between the students trained with the phantom head and the virtual reality system, which I think is to be expected. I mean, it would be very surprising if somehow the virtual reality system, the students did better than with training on teeth, right? Because we're not doing anything, we're not providing them with any kind of special feedback here. It's just straightforward practice, okay? So this was the first test, and so this was very nice to see that, yes, this does actually improve performance on real teeth. So the next question, which starts to become more interesting, is how can we use the simulator to provide enhanced feedback? So feedback that is perhaps not possible in the physical world. Well, one of the nice things you get if you have a VR environment is that you get data not just on the outcome, right? So you can actually analyze the outcome of a procedure, but you get data on the procedure itself. So within this domain, for example, we have the movement of the drill in the mirror, right? There on the left, you can look at the path. We have the amount of force that's being applied at each point in time. And we have the angulation of the burr relative to the axis of the tooth. Okay, so data like this that, of course, you would not have if you're just training somebody on a phantom head. And so, what can we do? Well, we can analyze the outcome. Okay, and then we can analyze the procedure. Get information on the hand movement, the applied force, the orientation, the amount of time taken. We can analyze the relationship between the procedure and the outcome. now. And we can provide feedback in a whole number of different ways. And I'll talk about the different ways we can provide feedback. Let's see, do I have a slide on the feedback? Yeah, so let me go back. So in terms of the outcome for this procedure, what we can do is we can generate a template that tells us what is the optimal outcome. And then we have some tolerance that says, well, if it's slightly over-drilled, it's still okay. Slightly under, it's still okay. And then we can analyze the outcome relative to that template. So that's pretty straightforward. And the other thing we do is that we can then, once we have a score, and we would score, in this case, the 4 walls of the tooth and also the floor, then we can also translate this into a language that's commonly used in dentistry to provide feedback to students. We did do this, and we also gave experts teeth to score, and we compared the automated outcome scoring with the expert scores. So, of course, that was always published as a journal article. But then what we can do also, once we have this analysis of the outcome and we know where was there over-drilling of the tooth or under-drilling, is that we can look at the procedure and we can look at where did this occur. So over-drilling, of course, there may be several times that region is visited, so it may occur actually in several points in time in the procedure. And then we can provide feedback. So looking at those parts of the procedure, we can do visual and textual feedback, so you can show just sort of statically the outcome and where the errors are. We can show the actions, and I'll show that in a second. Or we can even teach haptically. So if the student was using too much pressure at some point, we can teach them how much pressure to use by using the haptic device as a kind of a feedback, saying, hold the device steady and I will push against your hand to show you how hard you should be pushing. So that was one type of feedback we tried, which worked, and we published a paper back in 2017 on this. This is another type of feedback, what I just sort of mentioned on the last slide, augmented playback. So what we do here is that we know where there were regions, for example, of overcutting. And so what we can do is that we have a log of the entire procedure, like a movie, right? And we can have this playback bar. And what we do is we can color code the playback bar to show the student where they were overcutting the tooth, okay? So now, instead of saying, look, you overcut, the student can then also go back, right, rewind, and view that part and see where they overcut. They can also view an expert's performance at the same time to see how to get some comparison, okay? The other thing that we can do with this that's quite interesting in a VR environment is not only can we visually rewind it, but we can rewind the simulation. So you can, after you've drilled, you can undo the drilling, right? You put the voxels back. So if the student did everything fine until that first region of overcutting, they don't have to practice that part again. They can go to exactly the part where they were making the mistake and try it just there, right? So that's actually quite nice, this ability to rewind back in time and let the students practice just certain parts. So as we usually do, we did another randomized controlled trial to evaluate the effectiveness of this type of feedback. And so we had 3 groups of students. Should have maybe been more students, so the number was a bit small, but sometimes it's hard to get as many students as you want. So we had the experimental group using the VR simulator with no feedback, the group VR simulator with that feedback that I showed you, and then students trained on the phantom head. And we again, typically same design as before. We have a pre-test and we have a post-test. In this case, rather than using extracted teeth, we used plastic teeth. There are plastic teeth that are available. They're a bit expensive, but they are very realistic. They have the right densities and they have the internal anatomy with the roots. So you actually don't have to use the extracted teeth. Extracted teeth are tricky because oftentimes they're in poor condition. And so it's easier to work with the plastic teeth. So what we found in this study is that the simulator without feedback, and here it's sort of flipped, the higher the score, the better. The students did slightly better, the simulator without feedback, but not a big difference. The phantom head, they did improve after practicing, but we saw a much larger improvement with the students who got the video feedback. Okay, and this is, all students were getting feedback on the outcome, right? So they were all told if the outcome was fine, but the video feedback, of course, we're getting feedback on the process. And it turns out that that's quite important. We have done other studies of feedback on the process. We had a paper on something called augmented feedback, and that I'm not going to cover in this talk, but that also showed that these different kinds of feedback can be very effective. Right? And so, again, I just want to emphasize, I'm talking here about dentistry, but this can apply to any area of surgery. It doesn't have to just be dentistry. So another important skill in dentistry is indirect vision, right? And this is quite challenging for students to learn. So learning how to use the mirror when they're working on a tooth that they cannot view directly, okay? And so we wanted to be able to assess mirror usage. And if you think about it, how would you teach somebody how to use a mirror? It's not very easy because you can't know what they're looking at, right? So you can't say, yes, you're using it correctly because you don't know what they're seeing in it. And if you stand there, you see something different because your head's in a different position, right? You can ask them what they're seeing, but it's tricky to teach. It's tricky to teach. So what we decided to do, remember that study I mentioned of eye tracking for arthroscopic surgery, we decided to use eye tracking here as a way to assess students' use of the mirror. And so some of the questions we wanted to answer are, what information on a dentist's skill level can we gain by looking at the mirror usage patterns? How important is proper mirror usage for successful learning? And how does mirror usage in a VR simulator translate to performance on the physical teeth? So again, this translation from virtual to real world. So these were the questions we were interested in. So here, we designed a study with 30 students. We had 3 training sessions on each of 2 days with a washout period between, so we could also look at retention of skill. So you train for 3 days, do nothing for a week, and then train again. And you can see from that last training to the first group to the first of the second group, is there any loss of skill or performance? We did pre and post test on, it says real teeth, it's actually plastic teeth, but realistic plastic teeth. And we also had 6 experts, so we had a baseline for comparison. Oops. So here is what this looks like. So what you see here is, this is the eye tracking. So we're casting a ray from the eyes to the mirror, and you can bounce this ray right off, and so you know what they're looking at, right? The eye tracking gives us, we're able to, the eye tracking is basically like a little camera that tracks the eyeball, okay? And so we can know exactly what the students are looking at any given point in time. And that's quite nice, because now we can get quite detailed information about where are students looking, how long are they looking at a tooth? Are they looking at the tooth while they're drilling? Are they inspecting it? They stop drilling and inspect it. How often do they do that? So all kinds of metrics that we can gather this way. It's not 100% perfect because the eye tracker is not 100% precise. So you do have to deal with a bit of noise, and I think you could sort of see that. Come on. Why is it not playing again? Let me try to get it to play again. Yeah, there. You can sort of see it's a little bit jittery, right? So one does have to do some filtering to deal with the jitter. That's a downside of the current technology. It's just that you get that even with. So here we're doing eye tracking with the HTC Vive Pro Eye, which has eye tracking built into the head-mounted display. And with the cadaver study, this was cadavers, and so we used it's called Tobii was the company, Tobii Eye Tracker. So they're just looking at what they're looking at, and the Tobii Eye Tracker just has a couple of cameras that are looking at the eyes. But even the Tobii, you get this kind of jitter. You have to do calibration very often. It's still a somewhat developing technology. So we were looking at things like mirrors correctly positioned. Does the handpiece obstruct the vision? And so we looked at correct mirror pose versus simulator error. And you can see that we have a percentage of time, that's percentage of time, with correct mirror pose and simulator error, there's a nice correlation between them. And then we looked at learning gains. So this is looking at the post-test, pre versus post-test, so the difference in performance. And again, on the real teeth or the plastic teeth, you do also have correlation. So that kind of correct use of the mirror also translates to performance on the real teeth. Correct use of the mirror, I mean correct use in the simulator. And you can also see that if you look at this graph, this is the correct mirror pose drilling, so the percentage time over the different trials. We've got 6 trials plus the washout in between, and the blue is the students, the red is the experts, and you can see that the students are improving over time, and not surprisingly, you see from trial 3 to trial 4, there's a 1-week difference. You do see a decline in performance, which is completely to be expected. You do get this normally, but you also do get then your final performance is better than you had in the first 3 trials, right? So again, this is what you do normally expect to see with training, right? That first one it drops a little bit, but then later we see improvement. So we've seen this in other types of trials we've done too. So day 1, novices were worse than the experts. Day 2, novices were on par with the experts. Oops. What happened here? Wrong button. Okay. Right, so another metric. So we tried to come up with some different metrics that would be interesting, and one is vision breaks. So vision breaks is there a break in their observation of the tooth for 1 second or more? We call that a vision break. And it turns out that novices have significantly more vision breaks than experts do. So if you look at that graph, you see vision breaks on the y-axis and the training on the x-axis, and the novices always have more vision breaks. So periods of a second or more where they're actually not looking at what they're doing, okay, which is I'm not sure what they're looking at, but they're not looking where they should be, which is interesting. But they did also improve significantly. And the other thing is, if you look at vision breaks and simulator error and error in the learning gain, so error in the real world, again, we have this nice correlation. Not quite as good as the previous one. Actually, the simulator is better, but in the real world, it's not quite as good as the previous, but still significant. My colleague is, I think he is right now presenting this in Orlando, Florida, at the IEEE VR conference. Yeah. I think he's there this week, actually. That's the top VR conference. So, right, so now I want to move on. So everything I've been talking about has been psychomotor skills. And now I want to move on to decision-making skills. So this is more cognitive aspect. And so here we are now starting to get into the use of AI and integration of AI into the virtual reality simulation. So our objective here is not just to have students memorize actions, but we'd like them to understand why certain actions are necessary and why they need to be done in a certain way. And we want to enable them to make decisions in novel situations. And because of that, they have to develop a deep understanding of the causal relations in the domain. If I do this, this happens for this reason. And they need to be able to develop situation awareness skills, right? So continuously to be able to assess what is the state of the patient, what are the key cues to look for, what do they mean? When I see something, what does it mean? If the tooth is bleeding, is a little bit of bleeding okay? Is a lot of bleeding okay? What does it mean, right? If there's a lot of bleeding, it means something, right? It'll mean you perforated the floor, right? If there's only a little bit of bleeding, that's kind of normal, right? So interpreting what they're seeing, so this kind of situation awareness skills. So these were the things we wanted to be able to teach. And this is pretty challenging. So we decided that, well, we've got instructors who are very good at teaching these things. So what we did is we carried out an observational study where we went into the clinic, and we did this at Thammasat University. I have to apologize, it was not done here. There's a very good reason for that, which is that dentist I worked with there was my student when I was at AIT. And so we just continue to collaborate. She's now the vice president, so it makes it even easier to work with them. So we recorded the interactions between experts and students, and we also interviewed the experts to understand when they intervened in some way, why were they telling the student that? What were they trying to teach them? And so we analyzed this to identify what are the decisions that are being taught or being made by the students, what are the teaching strategies that the experts are using, what are the objectives of these teaching strategies, and what are the elements of situation awareness. So we went through and did this observation, did this analysis, and came up with different teaching strategies and sort of when they should be used. And so then what we did is we took the simulator, and you see that on the left. It's the same VR simulator you just saw. And then we added an intelligent tutor on the right. So the intelligent tutor has a domain model which basically models the procedure and the effects of different actions in a symbolic way. And to do that, we used an AI planning language called PDDL that can model conditional effects of actions. We have a pedagogical module that runs over the domain model and actually a student model and generates tutorial interventions. Okay, and within the simulator, we had to add an action recognition component because the tutor needs to know what the students are doing, right? So is the student making the initial access opening for the root canal? Is the student widening the opening, right? What is the actual action that's currently happening? It's not enough just to know the kinematics. And so the action recognition module takes the kinematics and generates a symbolic action. Says, this is what's happening right now. And then that gets fed to the tutor. The tutor sees what the student is doing and then can provide feedback. So I mentioned this, the representation of the surgical procedure is based on an AI planning language. Within that, we incorporated elements of situation awareness, so perception, comprehension, action, outcome. So we have, basically, these are logic statements that say, well, how do you interpret different cues? And then we came up with generic teaching strategies that run on a surgical procedure representation. So instead of hand coding these teaching strategies, these are generic strategies that you can give a data structure that represents the surgical procedure, and the system can generate tutorial feedback. So you could change the procedure and it would work just fine, right? So it's independent of the procedure. And there are a number of kinds of feedback that, and this was based on the observational study, so positive feedback just saying, yes, that was fine, keep going. And actually with the positive feedback, we use audio because we don't want to sort of interrupt the flow and have the student have to look at a text message. So we just say, good, keep going. Negative feedback if something was wrong. Asking for the rationale behind a decision. So, yeah, that was fine. Why did you do it? Inquiring into the cause of an unusual situation, right? And posing a hypothetical. So hypothetical is, all right, you used, I don't know, this clamp on this tooth. What if we change the tooth? What would you do, right? Or what if you were working on a tooth that was not structurally sound? How would you change your approach? So posing hypothetical questions and providing hints. So the way that the tutor runs, it doesn't, if it asks the student a question, it doesn't, and the student can't get it right, it doesn't just give them the answer. It generates a hint and tries to get the student to figure it out, help them a little bit. And we can do that because the data structure we use has an abstraction hierarchy. And so we can use the abstraction hierarchy to generate hints without telling them the exact fact. So the kinds of stuff we can generate, you see the human tutor observed feedback. This was just one piece of feedback we observed that said, open some areas for breathing, otherwise the patient will get syncope. Look, there's no area for breathing. The automated tutor generates the text that says, you inserted the rubber dam and clamp in such that the position of the rubber dam covers the nose of the patient, and the patient is at risk of syncope. So, and that text is not canned. It's not just a piece of text that we grab. It's generated automatically. So this we evaluated, and we oftentimes what we do is we'll, instead of just evaluating the overall system in terms of performance, we'll evaluate components to see how well do different pieces of the overall system function. And so what we did here was to look at whether the feedback generated by the system was reasonable. Okay. And so we had a number of case scenarios where we said, okay, this is what the student has done, and we showed it to some instructors and said, would you intervene, and if so, what would you say? Okay. So for example, I don't know, maybe the student has perforated the tooth wall. Would you say something at this point, and what would you say? And these were, and we gave it to our intelligent tutor, and the tutor generated its feedback, and then we gave it to experts that were basically had much more experience, and had them score the feedback to say, is this on a 5-point scale? Is this high quality, or is this not reasonable feedback? And then we looked at the difference in the scores, and it turns out that the intelligent tutor actually did a little bit better. And partly because the tutor tends to provide pretty detailed feedback in a very consistent way, and the human tutors don't always do that. And then we looked at the effectiveness. And so again, a randomized controlled trial where we had a pretest, so we were asking questions now, questions concerning decision making, and then we had a control group, an experimental group. The control group was taught by human tutors using the phantom head to just the standard way that it's taught, and the experimental group was taught with our system, which we call SD Mentor, for both for 3 days, and then we had the post-test of, again, questions about the same topics but formulated differently, so not identical questions. And so what we found here is that the control group, before the training, so control and experimental were getting scores of about 40%, so both of them about the same. The control group improved, but the experimental group improved quite a bit more. And again, we did look at, why is this happening? And it tends to be the consistency of the feedback when the system is being used and the detail of the feedback. So we've actually observed this with other tutoring systems that we built, this kind of consistency, especially if you're talking about long training sessions. The human tutors can get a bit tired, and the quality of the feedback can deteriorate over time, and the machine just doesn't get tired. So let's see. So a few conclusions. I don't know how we're doing. I think we're good. So virtual environments provide really a new opportunity for more effective teaching. We can get detailed data on problem-solving activity, not just the outcome, but the actual activity itself, and new modalities for feedback and guidance that are not possible in the physical world, things like rewinding a simulation. The techniques that I talked about today are very general and apply across a wide variety of domains. My colleague, Gabriel Zachman at the University of Bremen, with whom I've done a lot of the development of what you saw here today, has also worked on a hip surgery simulator, and using very much the same algorithms. In fact, the same algorithm that's used for haptic feedback for the teeth is used for the hip. But for the hip simulator, you need a lot of force. And so we can't use these little haptic devices. So he actually uses a KUKA robot arm as a haptic device for that simulator. Expensive, but it works. So ongoing work, we're looking at one interesting question is, can we differentiate between cognitive and physical sources of errors? Yeah, right. When somebody makes a mistake, it can be because they don't know what to do, or it can be because they know what to do, but they don't have the physical skill to carry it out. And it's good to know which of the two in order to be able to provide the right feedback. We are also a colleague in Bulgaria who has some fMRI equipment and is very interested in looking at using fMRI to look at the effects of different training modalities, and of course application in other medical domains. Lastly, just want to thank my collaborators. This is a short list of collaborators. There are many more on here. And some of them are former students. Actually, a lot of them are former students, I guess. And others are collaborators at various universities. And our funders, PRF, and the Hansa Wissenschaftskolleg Institute for Advanced Study, which is located in northern Germany, has been very, very supportive of our work. So, thank you very much for your attention. And I'd be more than happy. We have lots of time, so more than happy to answer any questions you might have. I did leave out quite a lot of work.
Thank you, Professor Hattevi. Any question from the floor? Okay. During this time, maybe I can ask some questions. Let them think first, okay? You mentioned a lot about the advantage of using the VE in the training. How's about the limitation of the using VE?
Yeah, there are certainly limitations. I would say one is quite hard to get the haptic feedback to where it is completely realistic, and that's partly a limitation of the devices. For one thing, the devices we use do not have any torque, so it's just XYZ. And if you want a haptic device that gives you torque feedback, so 6 degrees of freedom, the cost is much, much more, right? So these devices, I think we pay about 100,000 baht per haptic device, and that's the ones with torque are about 1 million baht. So yeah, it's a huge difference. And if you want something that provides a lot more force, again, that gets quite expensive. And these, of course, these haptic devices are just like styluses. If you want something that's going to give you tactile feedback, that also gets into money. So the technology is still developing. Computationally, I think, the machines are fast enough, so that's not a problem. We use PCs with high-end graphics cards. We have usually a 3090 now, 4090. 2 of them. We'll have one for graphics, one for haptics. So that's not too bad. The PC runs about 300,000 baht for PC. So I guess that's, those are maybe some of the limitations.
Okay. It is because I saw that you have a lot more ways to, for the stylus and haptics as well. So how's about the idea of choosing in case that some of them may have an idea to buy it and using it in their laboratories? What kinds of idea for selecting the kinds of that things?
Well, there are actually not that many out there, so the market is really small. The one I showed you is called the GeoMagic Touch, and that's the cheapest good haptic device. That's the cheapest good one. And then they get more expensive from there. So, but it's also not, you can't just buy one and use it. You've got to write software for it. Okay, so it comes with some demo software, some simple stuff like software that lets you, shape clay or something like that, right? What we've done, what you saw here is software we wrote ourselves. So there is you basically have to develop it yourself. And that's quite challenging. One thing we're working on now, so you saw with the root canal procedure, there is one part where you have to file the teeth, and that's quite interesting from a haptic standpoint because that's very, very hard to get the rendering right. Because these files they're very thin and they can flex. And you want the haptics right because when somebody's doing the filing, they can't actually see inside. So they have to use the sense of touch. So this sort of, this problem of modeling haptics when you've got a flexible instrument and friction is quite hard. We plan to work on that. The drilling is easier. Another thing that's hard, by the way, is modeling of soft tissue. So if you wanted to say to something that you could use for abdominal surgery, that is very difficult, right? That when you cut the tissue, that you're going to get the right behavior, that you get the right feeling. That's one of the reasons we're working on. I chose dentistry because I wasn't interested in spending all my time on VR, but I wanted to be able to explore integrating AI with VR. And so I wanted something that would be realistic enough, but not sort of suck up all of my time, right? And drilling on teeth or bones, or hard tissue, is much easier than soft tissue. So I thought that's a good area to focus on.
Okay. And just in case that I saw in some department they already have some kind of a soft tissues or soft cadavers, and how can we mix up between your VE and the material that already have in that department?
Okay. Oh, you mean that you've got some physical material? It is possible. So I mean, it is possible to have like, I mean, for example, with the vascular access simulator, right? So one thing, right, with the simulator, the way it is now, you have to just position the needle, but typically what people do is they will actually feel, right, where things are, put the fingers and then insert the needle. And you could actually do this if you had a mannequin. In the VR system, you can align the image with the physical mannequin. And so then you can allow the person to actually touch the physical object, but see what is being shown virtually, right? So that's possible. And of course, there's also augmented reality. So you can combine them. I have a colleague in Oldenburg who is using AR, augmented reality, to support liver surgery. So to project pre-operative images on the patient, right? So AR is very good for that, and there are a number of universities in the U.S., UCSF and Hopkins that are experimenting with the use of augmented reality to support surgical procedures, because you can still see the patient, right? But you can then also see the information, and you can position it so it's convenient, so you don't have to keep looking up at a monitor, right? You can keep your focus on the surgical side.
Okay. Any questions from the floor?
Thank you so much for your talk. It's very wonderful. One thing that I really want to know about is a lot of times we use simulation, VR or AR. It's very intriguing for a younger generation. And most of the time, maybe senior staff or middle staff might see it's not that realistic. The beginner might be benefit from it, but not us. What do you think about this, and have you ever test this out with the expert and let them say what they thoughts about these and what are their feedback on using this? I just very curious about that part, because we have the pain point about that when we're trying to implement these kind of new technologies.
Yeah, that's a very good point. I mean, you're right, and when we do our trials, we do see a lot of enthusiasm among the young medical students. They seem to really enjoy using these systems, and I mean, there's always a certain amount of realism you cannot capture in the VR systems, right? And so they do tend to be quite good for some initial training, and then move on to patient sort of physical models that are more realistic. But I mean, it's certainly possible to develop systems for training in procedures that are highly challenging, right? So where somebody who does have experience could still use it. But this would be interesting to look at. I haven't seen studies of this, right? So specifically looking at, can we target training systems towards people who have quite a lot of expertise? I have actually not seen any studies like that. So that would be an interesting thing to look at. I think most of the systems you said are really for more at the novice end, you know. But I have also gotten this kind of feedback from some experts that this isn't quite right and that's not quite right, and which, yeah, can be true. But you know, if you and of course, we think of this as and I wouldn't say you're going to replace traditional training, but as a supplement. The nice thing about a system like this is you can use it. It can be used 24 hours a day, right? There's no cost. Once you have the system, there's no cost in using it. So basically, students can get extra practice.
Thank you so much. I have you actually raised that point, but I would love to follow up with another question on that too. For right now, I think most of us might see this as an extracurricular, top up to what we already have in our curriculum. But I think sometimes we might not feel comfortable in investing in this. And what would you suggest in terms of, okay, if you want to add up to what you already have, in terms of using AI for VR, what would your recommendation to a very novice program that have never experienced about this before, but they interested in using one, which would be a good start that you would suggest them to invest in?
You mean what kind of system, or
what kind of system or what kind of tools that you would suggest them to use, for the first steps if they want to implement the VR?
Well, I guess there are two things. One is commercial systems. So there are nice commercial simulators like LapSim, right, for laparoscopic surgery, which is quite sophisticated, very expensive, but really nice. And in dentistry, there are a number of companies that build simulators, although they tend to be not fully VR based. So, one is that you can just go out and buy something. From my standpoint, it's a bit more interesting to look at developing something in-house because there are a lot of really interesting research questions, and so now you can generate some very nice research. And if it's you're a teaching hospital by nature, then it's of course nice to be experimenting with the technologies. But what area is it's hard to say. There's so many different areas you can work in. I think my experience so far has been you've got to get the people who are enthusiastic about doing this, right? And who are willing to invest the time. Because I have had positive and negative experiences, to be honest. So I have, sometimes had some people who initially expressed some interest, but then, they just didn't quite have the time and things didn't go anywhere. So you really do need, I'd say that's probably the most important thing, and get the right team. You got to have you've got to have people with the right technical knowledge and experience. Also, because if you're dealing with VR, a lot of it is experience-based still, right? It's not, you can't just open the book and see, okay, this is what I do. So there's a little bit of art involved in it, just like there is with AI. Yeah.
Thank you so much. I love that. Early adopters and teams is the key to begin with, and that was valuable. Thank you.
There is a request from Ajahn Thaksaon Pitipason. Could you please repeat the last 4 slides, the research in the last 4 slides? She said your slide is interesting, and
Which slides?
Last 4.
Last 4. This, or I'm not sure which.
I think it's this one.
Previous or next?
I'm not sure. Maybe get some reply from the text box.
This. Which one? This one? Okay. Yeah, this is not yet published. This is a manuscript that's been submitted. We're waiting for the reviews. Yeah.
Thank you.
But I think we submitted this to AI in medicine. There's various journals on medical informatics, medical AI.
Thank you very much. The audience said she would like to read more about it.
Oh, okay. The paper that we did publish already is this one. This is this first evaluation study. So that was published in AI in Education. Is the teaching system. So this was published in the journal AI in Education. That was back in 2022. And then this second result where so this we're just evaluating the quality of the feedback. And then we wanted to look at, of course, finally the overall effectiveness of the system. And that's that second, the slide with the bar graph. And that is under review right now. Yeah.
One quick question. I think I'm really impressed about how actually maybe like AI can provide a better feedback compared to like human instructors. But like as you mentioned earlier, I think maybe novice learner generally like AI technology. But I wonder in terms of accepting feedback. I think many of my friends still believe like, okay, I can get certain ideas from them, but getting feedback, maybe like experts can do better. And even in the face of evidence, like there are many examples, especially in education, like we can tell them what is the better way to learn, but they still stick with what they believe is better. So I wonder, like after we get this result, do novice learner like start to believe that maybe we don't need feedback from experts anymore and we can trust like machines to do certain of these feedback activities?
Yeah, so that's a good question. Yeah, there are a whole bunch of aspects to that. So one is, if you look at the feedback that we were generating, it was restricted to a somewhat narrow domain. So the system that I talked about here, it's not capable of carrying on a conversation if the topic gets too broad. And so one of the things we worked on was automatically extracting causal knowledge from textbooks. Because we wanted to build a much larger, broader domain. Of course, you could also use a chatbot, right? ChatGPT. But the problem with that technology for teaching medicine is that it's far too imprecise and inaccurate, right? So yeah, it generates text that sounds very good, right, and is grammatically correct, but may not be factually correct, right? So you need a technique to generate feedback that's actually correct. And so that's why we were trying to, and we made some progress on this, extracting causal relations from textbooks to have a broader set of knowledge, because you do really want that. But the other thing with this is that what you don't get with this is the emotional aspect, right? I mean, a good teacher is not just sort of standing here and interacting like a robot, right? It gets the students motivated and excited, and the students can see that in the person, right? And so I mean so I mean these systems will never replace human instructors. It's impossible. So, yeah, I think they have their role, and I really do think it's more supplemental, right? So if a student wants to, go home and practice something, or just go into the lab and use the simulator and get some practice, I think they're really useful that way. They're great tools, but I wouldn't say, okay, we don't need humans. I think what the message is that with this technology, we can do better than we can without it. Not replace what we have, but we can do better. The students can get better training, and they can perhaps learn the material faster, right? So better mastery, learn faster than without it, but I wouldn't replace anything.
Thank you so much.
Yes.
I want to ask about if I want to start producing in-house the AR or VR system for the simulations in terms of building a team to get to do that. It means that we have to have one graphic man to build a 3D, right? Another man for creating a software for the haptic system, and another one for the AI building system, right? So we need that.
You need it. Yeah, you need a team.
Yeah.
So, well, let me think what we have for what we've done. We have, so we usually, sometimes the person who builds the software also does the modeling, because when students are learning VR, they're learning modeling, but they need to be pretty good at it if you want to do, for medical purposes. So, with let's take the AR system for teaching anatomy that I showed you. So we had one student, he was actually an undergraduate, really good undergraduate, who built that. So he built the software, and it was amazing. He actually started during COVID, so he didn't even have a HoloLens. So he had to build it with an emulator. He couldn't even test it. But he also did the modeling of the knee and the shoulder and produced some very nice models, but then he worked with anatomists, right? So he went and they gave him the pictures and some plastic models, and then he built it, and then he went back and showed them and got feedback, so there was this sort of feedback loop. So you could have, some people who are good at building the software are good at modeling, not always, right? So sometimes you may need somebody to do the modeling separately. But the modeling is, if the person has a little bit of it takes a little bit of artistic skill too, right? The modeling, that's not too hard, and an undergraduate can do that. The programming, it depends on, usually I would say it's going to be somebody with a higher skill level normally for the coding, especially if you want to do haptics, that's quite hard. So if you look at the dental simulator, the simulator I showed you, let's see, the haptics was done in Gabriel Zachman's lab. So we had a haptic implementation, but he had come up with a more sophisticated algorithm, so we used his algorithm, and that was implemented by his PhD student, who was actually planning to come here, do a postdoc with me within the next 6 months, let's see. So we'll have somebody very good, by the way, here. And then the graphics was done by a group of undergraduate students as a group project. So all the graphics you saw, they did, and they did a really nice job. You see how realistic it looked. And let's see. And then, of course, we worked with a dentist. That was Professor Siriwan. Because we had to tune the haptics, right? And also even the graphics to say, okay, this is realistic at this point. And so again, working with the medical expert or dental expert to show them what we've done, get feedback, refine it. So a lot of these sort of loops. But you can do it with a team of, it doesn't have to be a huge team. Yeah. But that's where, the collaboration with faculty like ICT can work really well, right? Because we have the expertise there for VR. and we're interested in collaborating, right? So that can work.
So it depends on the haptics tool, right? If the model is changed, the algorithm is changed, the key man must relearn or have an expertise in the new model accordingly.
Well, if the model changes, the algorithm doesn't have to change. So like with our dental simulator, we can do any tooth, right? But we can even do something other than teeth because it's just drilling. So anything that involves drilling we can do. But if the handpiece, if the drill changes, okay, then a new drill model has to be built. But the basic algorithm would be the same. Or like for the VR anatomy, so we did the shoulder. I think we started out with the shoulder, and then we did the knee. And that was just building the model and loading it into the system. We didn't have to do change the software in any way. We just created a new model and loaded it. So if the software is built in the right way, you don't need to change anything if you have a new model. You just load the model and it will work. So that actually brings up a really interesting question, which is, if we have one of these simulators and we do this for an adult male, can we do it for an adult female now? Yes, right? And you don't have to change anything. You just load that model. Can we do it for a pediatric patient? Yes, same thing. You just load the model, right? So VR is quite nice in that you can have different kinds of models, patients with different pathologies, different ages, different sex, and you don't have to change the software. So that, I think, is something that's really attractive about VR systems.
Thank you very much.
Any more questions from online, huh? No more? Okay. So, thank you very much, Professor Hatavi, for your nice talk and also for the session of Q&A. We hope that maybe in the next event, Sirilat might have a chance to invite you again and hope to have a good collaboration together in the future. Thank you very much.
Well, thank you very much. Really enjoyed the discussion and some really great questions. And if you have any other questions, just feel free to email me.
Thank you so much. Thank you. And ขอกลับไปเป็นภาษาไทยนะคะสำหรับคนที่สนใจที่จะเข้าร่วม Pearls in Medical Education นะคะปีนี้นะคะ2024ค่ะอาจารย์ทางศูนย์ชีได้รับมอบหมายนะคะว่าให้เราเพิ่มหัวข้อแทนที่จะเป็นเดือนละ1ครั้งนะคะก็อาจจะมีเรียกว่าเป็นอีเวนต์พิเศษเพิ่มมาอีก 3-6 ครั้งด้วยกันนะคะก็เราจะประกาศเรื่อยๆนะคะทางสื่อต่างๆของชีนะคะในเดือนเมษายนเราจะมี2หัวข้อด้วยกันนะคะหัวข้อแรกจะเป็น Impact of Technologies on Health Science นะคะจากอาจารย์เดวิดเวิร์ดลีย์นะคะซึ่งมาจากทาง UK นะคะในวันที่3เอพริลนะคะ3เมษายนนะคะบ่าย 2 ถึง 4 โมงเย็นทาง Zoom เท่านั้นนะคะถ้าเกิดว่าท่านใดสนใจก็สามารถลงทะเบียนได้เลยตั้งแต่วันนี้เป็นต้นไปนะคะอีกอีเวนต์หนึ่งนะคะอันนี้จะมีทั้งเป็นไฮบริดนะคะทั้งออนไซต์แล้วก็ออนไลน์นะคะในวันที่10เมษายนหัวข้อจะเป็น Hybrid Learning in Medical Schools นะคะจะเป็นอาจารย์จากเซนต์ลุค Medical Center College of Medicine จากทางฟิลิปปินส์นะคะซึ่งอาจารย์มีประสบการณ์การทำงานในเรียกว่าโรงเรียนแพทย์ของทางสิงคโปร์มาด้วยนะคะเป็นอาจารย์ลีดันเต้เมนโดซานะคะถ้าท่านใดสนใจนะคะ3เมษายนแล้วก็10เมษายนนะคะก็จะวันนี้เรื่อง VE นะคะถัดไปก็จะเป็นเรื่อง Impact ของการใช้เทคโนโลยีต่างๆในด้าน Health Science นะคะแล้วก็จะเป็นอีกอีเวนต์หนึ่งก็คือลองเอามาใช้ซิว่าถ้าเป็นเราทำเป็น Hybrid Learning ใน Medical School ในต่างประเทศทำอะไรกันบ้างแล้วนะคะก็หวังว่าจะได้มีผู้สนใจลงทะเบียนมาตามเจตนารมณ์เป้าหมายของคณะแพทยศาสตร์ศิริราชพยาบาลนะคะวันนี้ขอบพระคุณทุกท่านมากนะคะ